wanted to talk about metastatic spine tumor management. Obviously, this is my clinical and research interest after finishing my fellowship last year with Dr. Bilski at MSK. Obviously, my main goal here would be to sort of build up the program at UW and SCCA. I think we can really become a national powerhouse, which we pretty much are already, but I think programmatically we could really make it much more cohesive. So I was hoping to eventually bring some of the things I learned from MSK over here in the coming months. So and just in terms of the objectives, we'll be talking about the NOMS decision framework, which was created by my mentor, Dr. Bilski at MSK, as basically just a framework of how to think about patients with spine tumor metastases and how to manage them. And then we'll also be describing the epidural spinal cord compression grade and its role in helping us determine radiation treatment planning and where surgery fits in. And then finally, one of my personal interests is minimally invasive surgery. So I'll also briefly talk about how we can incorporate MIS into spine cancer surgery. I have no disclosure. So just as a brief introduction, as you all well know, metastatic spine tumors are fairly common in patients with cancer. More than 20% of them will eventually develop spine metastases. And this prevalence is actually increasing year by year, probably from having better detection with more frequent surveillance screens with MRIs and PET scans, as well as that we're having improved survival over the years as systemic treatment options are improving. And a lot of these systemic, like targeted therapies, checkpoint inhibitors, while they have pretty good penetrance in the visceral organ, they don't penetrate as well in the bone. And therefore, we're seeing a lot more of these bony mets developing in people who are surviving longer. And then finally, just radiation therapy, SBRT, talking about stereotactic ablative radiotherapy, has really changed the oncology field. And again, patients are surviving much better while we're getting really good tumor control with high dose radiation. So all this leads to more patients suffering from spine tumors, which can really cripple someone's remission if their phase of remission and their functional being. So really, when we talk about metastatic spine tumor surgery, we're really thinking about the palliative goal. So how can we improve the quality of life? And there's various ways that we need to sort of factor the various things that the patients really value, such as providing pain relief, stability of the spine, preserving neurologic function, and then finally local tumor control. But really, the ultimate goal with all these four components is improving quality of life for these patients. The care for these patients is obviously multidisciplinary, and it's used as a combination of systemic therapy, in which we include the aforementioned chemotherapy and newer modalities such as targeted therapies, immunotherapy, radiation, and we'll go into a little bit more details about the various modalities of radiation. And then, of course, with us, with surgery. And again, we'll go into a little bit more details of the various options, open surgery, open traditional surgery versus percutaneous fixation. Do we do a separation surgery and block, intralesional? We'll go into a little bit more details about that. So when talking about these very, very complex patients that have multiple systemic issues, I think one of the things as a resident for me is that I got very lost in all the details. They've had this history of this cancer, they've had this systemic therapy, they've done this radiation, but they had this type of pain. And it was very hard for me to sort of integrate that all into a cohesive plan and assessment for that patient. And so one of the big things for me when going to my fellowship at Sloan Kettering was that I really wanted to see how an expert can sort of integrate all these various principles. And one of the things that I wanted to go to MSK, one of the reasons why I wanted to go to MSK was because Dr. Bilski has created this NOMS framework, And it was just like a very systematic way to sort of understand patients and all their different components of their care. So that's, I will be going into details with that, and we'll just repeat it several times throughout this presentation. But basically, the NOMS stands for Neurologic, Oncologic, Mechanical, and Systemic. And these are the various fundamental principles that we need to consider for every single patient that presents with a spine metastasis. The neurologic is looking at what sort of symptoms are they having, how compressed the spinal cord is. Oncologic is really talking about how sensitive to radiation that tumor histology is. Mechanical is considering how unstable the spine is from their disease and can they withstand physiologic loads. And finally, the systemic burden of disease, also including their medical comorbidities, can they handle surgery? So we'll first start off with the N for neurologic. And basically, in addition to looking at if they have myelopathy symptoms or radiculopathy, the major factor based off of imaging would be looking at if the patient has epidural spinal cord compression. So we can break this down based off of into two various categories of low grade versus high grade cord compression. And we're really looking at the T2 axial weighted MRI sequences at the level of the tumor. So I'll just try to zoom in here. So for grade, Bilski grade 0, it's really talking about disease that's limited to purely the bone, and there's really no encroachment into the neural structures. Whereas grade 1, which has a subgrading of ABC, is really when the tumor starts encroaching out of the bone and encroaching upon the fecal sac. And then for what I would consider high grade would be grades 2 and 3. And for grade 2, it's when that tumor has deformed the spinal cord, but there still is usually CSF present. And then the big distinguishing factor for grade 3 is that there really is no CSF present. It's basically the entire canal has been invaded with tumor and the spinal cord is totally compressed. Now, this becomes a big factor, that degree of compression, because different tumor histologies have variable sensitivity to radiation. So in this summary table here, which is based off of several studies, we've broken down various cancer types and then broken them and categorized them as radiosensitive versus radioresistant. And basically, the blood-based cancers, as well as prostate and breast, are considered radiosensitive, whereas more solid organ tumors such as renal cell, lung cancer, GI tumors, melanoma, and sarcomas are considered radioresistant. So when compiling all these studies, what we can show that when patients are getting conventional radiation, for the radiosensitive tumors, they have a mean local control of 11 months and 2-year local control of 86%, versus in the radio-resistant populations, we're only getting a median response of 3 months and a local control of an abysmal 30%. So really, we have to understand what tumor type the patient has, because an L4 tumor from myeloma is going to be totally different treatment plan than the L5 tumor from renal cell. Moving on with the NOMS paradigm, then we get to M for mechanical. And this is really, can the patient withstand the physiologic loads of normal daily activities with their tumor burden? And another way to assess this with a nice algorithm, and to put a number to it, is the SIN score, the Spinal Instability Neoplastic score. And most of these parameters are based off of imaging. So we're looking at location, pain, the type of bone lesion, if there's any misalignment, how the vertebral body is affected, and posterior elements. And so basically, the big things to look out for is, in terms of location, is if the tumor is at a junctional level, like C7, T1, T12L1, and that's going to be considered more unstable. And then is the patient having mechanical back pain versus biologic back pain or no pain? And we define mechanical back pain as pain with ambulation or sitting or going from a lying position to sitting position, etc. Whereas biologic pain is most of these patients will have some type of cancer pain. And that type of pain is usually much worse at night, and it gets better throughout the day. And we believe that's related to just the diurnal steroids that your body makes. And you probably have more inflammation in the middle of the night as you're sleeping with your basal steroid rate going down. And then in terms of the bone lesions, tumors that end up being more lytic are believed to be more unstable. And then if there's any alignment issues like subluxation, or we often see a focal kyphosis. And then in terms of vertebral body, often we see these patients presenting at first with a vertebral body fracture. So trying to really look at what's the vertebral body height. Is it more than 50% collapse or less than that, or how much of the vertebral body is involved if it hasn't fractured yet? And then finally, are the posterior elements involved, the pedicles, the bed joints, the lamina, sinus process? And so then for every single patient, you can sort of tally up a score. And if it's between 0 to 6, we consider that relatively stable and probably does not need fixation purely from the spin score. And then obviously a very high score from 13 to 18 is very unstable, and we would recommend stabilization. And then 7 to 12 is sort of dealer's choice, and that's where sort of the art of medicine comes in, evaluating the patient. And obviously you can't just make all your decisions based off of that first initial CT. And so you'll find that a lot of patients end up in that indeterminate category. And that's where the real decision making comes in. And finally, for NOMS, I think this is the biggest one that's still undefined, is systemic, and understanding the patient's extent of tumor burden, their medical comorbidity, and what's their predicted survival. Very hard to still predict this. There has been some recent advances. So this was one study by a cohort, a multi-center trial that created this Nomogram based off a lot of retrospective data. And you can find this calculator online, but briefly, you can just put in what your patient's current disease state is, and this Nomogram will have a fairly decent prediction of how long they're going to survive. And this can help us predict, to assess sort of how big of a surgery should we do, or really, should we sort of start that palliative care hospice discussion instead. So now we'll go into a little bit more details of each of those various categories of NOMS. So really for the neurologic and oncologic, we end up considering both of these components together. And so right now, basically you need to consider how compressed the spinal cord is, and also how sensitive to radiation that tumor histology is. And so again, another table we've created here is just trying to figure out if the patient has low grade versus high grade cord compression, and then if that tumor is considered radiosensitive or radioresistant. And then what you can see right here is that basically if the patient has a very radiosensitive tumor type, like multiple myeloma or some type of lymphoma, you can proceed with conventional radiotherapy for most of these patients, regardless of how high grade the cord is compressed. These very extremely radiosensitive tumors, and they will really essentially melt after a few weeks of the treatment. Now, the story gets a little bit more complicated with these radio-resistant pathologies. So if you have a patient with a radio-resistant tumor, such as renal cell, and they have a low-grade compression, then we can give a very high dose of ablative radiotherapy, such as stereotactic radiosurgery, if it's a single fraction, or a hyperfractionated treatment design. And that also will treat that tumor without surgery because you're able to provide a very high dose of radiation while having minimal toxicity to the spinal cord, given that there's very low grade compression. And then the issue really becomes when you have a radio-resistant tumor with high grade core compression. And in this case, we're very reluctant to give a high dose of radiation, as this will provide a lot of toxicity to the adjacent spinal cord and nerves. And this is really where there's become a main role for surgery. Typically, what we end up performing is what they call separation surgery, which we'll go into detail. And so typically, you end up doing surgery plus the radiation. And we'll go into a little bit more details in a future slide. And now these definitions of high grade versus low grade and radiosensitivity, these are always changing as the field is advancing, both in terms of combining radiation with other systemic things like immunotherapy, and also with the advancing technologies of the radiation technology. So I often think about this as more of a spectrum rather than these defined categories of high grade and low grade, or radiosensitive and radioresistant. But really, if you have a tumor that is relatively radio sensitive and with minimal core compression, we should be fine proceeding with conventional radiation. And then as that tumor type becomes more and more radio resistant, that's when we start thinking about much higher doses of radiation, and that's where you get to stereotactic radiosurgery or ablative radiotherapy. And finally, if you have a radio-resistant tumor with significant cord compression, that's when you need to start thinking about a surgery as part of that treatment plan to really protect the spinal cord, the nerve roots, and provide a better target for our radiation oncology colleagues. Here's just an example of a patient that I saw in my fellowship with multiple myeloma, who had a pretty significant cord compression here. We would call this a grade 3, where you don't really see a CSF at all. And then this patient, we proceeded with radiation, conventional, 3 grades over 10 fractions. And essentially, this tumor really just melted away in a matter of 2 weeks. So again, so the patient never needed surgery from us. Now, just going a little bit into the different modalities of radiation, when we talk about conventional radiotherapy, we're really talking about giving multiple fractions of radiation treatment with with a very low dosing. Typically for the spine, it may be 3 grades and 10 times 10 fractions. The benefits of this is that it's very easy to plan, it's less complex. So this can be done at many hospital centers. And also, if you have patients with multiple levels of tumor, it's very easy to plan using conventional. It's very easy to get large volumes in your treatment plan. And here's just a representative example of a patient who was getting conventional radiotherapy. And what you can see is very quick to plan this, basically a block of radiation. Because it's a low dose, you can get away with providing some radiation to the spinal cord. Now, the real game changer has been stereotactic radiotherapy. And the benefit of this is that you're giving a very, very high dose, basically an ablative or cytotoxic dose. And that's why we believe that the histology is less important. We're giving 8 to 10 grades in either 3 fractions, occasionally 24 grades in 1 fraction. So this has probably been the single greatest advancement in the last 15 years in spine metastasis treatment. It's really changed that surgery paradigm, because now we can really, instead of doing a huge open surgery and trying to get every single tumor cell out, we basically have shifted the paradigm to doing enough surgery to protect the spinal cord, the nerve roots, and providing a safe target, and then depending on the stereotactic radiotherapy. And the disadvantage is, of course, it's more expensive, takes longer time and more resources to plan. And so right now it's pretty relatively more limited to major academic centers in comparison to conventional radiotherapy. just to give an example of that ablative dose, here is one study looking at single fraction stereotactic radiosurgery. So these are all patients that received 24 grays in one fraction at MSK. And basically, regardless of what tumor histology it was, at 3 years, they were hitting about low 90% control rate. And so even radiosensitive, like moderately radiosensitive, like breast cancer and prostate, and then even the ones that are considered typically radio resistant, we're getting that low 90% to mid 90%. And we believe this is just, we're giving such a high dose that you're really just providing a cytotoxic dose to these tumor cells. Again, just to reiterate, the dosing of that radiation makes a big difference. So there's various treatment paradigms. And in this one study, there was they categorized low dose as people who received a median dose of 16 gray, whereas high dose was receiving a median dosing of 22 gray to the tumor volume. And you can see over the years, 1 year, 2 years, and 4 years, the group that received the high dose had really good tumor control, barely having any failure of only 2% at 4 years, whereas in the low dose group, the local failure was already 5% at 1 year, and then just went up precipitously at 2 years and 4 years. So as I mentioned, radiosurgery and ablative radiotherapy really has revolutionized our surgery options and what we need to do. So it's not a question of what can we do. We know, for example, 15, 20 years ago with a solitary renal met, we would do a big end block resection, perhaps a front back with an anterior cage, really decompress everything. But there were certain morbidities associated with a bigger surgery. This operative time in this one case report was over 15 hours to do a front back surgery with a mean EDL of half a liter. So now in the more recent years, when we can sort of integrate, really needing to do surgery, reserving it for when you really need it versus go into radiosurgery, you can see there's a big difference. So now this patient with the same lesion in more modern times, they may not need surgery at all. They'll go straight to radiosurgery. They have a 20-minute session, no blood loss, and they have 98% focal control. So just one of the main recommendations from the SOSG group is that they have a strong recommendation that radiosurgery should be considered over conventional fractionated radiotherapy for treatment of solid spine tumor mets, and also for radio-resistant histology when there's no other contraindication. And the group society's recommendation is that SRS is considered safe and effective treatment, regardless of the radiosensitivity to conventional radiation. So now the big question about where we fit in is really these high-grade spinal cord compression cases. The main issue is that, as we showed in the previous slide, that you have local failures when we're having insufficient dosing. And basically, if you're hitting more than 15 gray, you're having really very minimal local failures when you're getting 15 gray to the tumor. The main issue, though, is we have to prevent spinal cord toxicity. And spinal cord in itself, typically we consider the max radiation that it can receive is less than 14 gray. So as you can imagine, if you're having a tumor that's having high-grade cord compression, we're going to be underdosing the tumor treatment volume, given this proximity to the spinal cord. And so you can see here in this patient's plan, this blue line here is really the tumor volume. And then this is the planning volume for the treatment. And what you can see is that oftentimes you have to sort of pull back that treatment plan to prevent spinal cord toxicity. But then this region here, where the region that has epidural compression from tumor, is the part of the tumor that's being underdosed. And so there's no surprise that these patients are going to progress to having failure as well as spinal cord neurologic issues with myelopathy or radiculopathy. In terms of, there has been a few studies of looking into does radiosurgery in itself can it cause disease as a decompression method? And the issue is that while the tumor and the will ablate and shrink down and melt away eventually, this can take several months. And so there's no real true effective decompression of epidermal disease from radiation alone. And obviously, while you're having months and months of waiting for this tumor to necrose and die off, that patient is at a high risk of myelopathy development. And so this becomes the big paradigm of when we should intervene. And there's this one major study, landmark study in Lancet by Patchell, really looking and evaluating the surgical indications for treatment of spinal metastasis. You guys have probably read this before in Journal Club, but really is one of the main landmark studies, prospective, randomized, looking at solid tumors with high-grade core progression and randomizing them to radiation alone versus surgery plus radiation. And this is really the best evidence that we have that show that patients who receive both a surgical decompression plus the radiation did far better than radiation alone. And this looking in all categories in their study in terms of overall ambulation, life, overall survival, local control, bowel bladder continence, use of pain medications, and then overall survival. So basically in every single category, the patients who underwent surgery plus radiation did far better than radiation alone. Based off of this landmark study, the spinal study group recommends strongly that patients with high-grade spinal cord compression due to a solid tumor malignancy undergo surgical decompression and stabilization followed by radiation therapy. Now, the big question is, what is the right surgery to do for these patients? So we've in the literature, they've coined this term, separation surgery, and basically it's not sufficient to just perform a laminectomy, as most of these tumors are arising from the vertebral body, which is ventral to the fecal sac. So basically, we first typically perform a stabilization with posterior pedicle screws. We then perform a posterior lateral decompression, doing a wide laminectomy and removing the pedicles. And then as we go circumferentially around, we decompress the fecal sac with any tumor that is present both ventrally and dorsally. And we don't necessarily need to go chasing and doing a full vertebral body corpectomy. Really, we're doing a partial corpectomy in most of these cases with the goal of freeing up that ventral fecal sac from any cord compression. Now, just as an example, we have a patient here with a high-grade cord compression. Here is their pre-op MRI. Again, showing pretty much no CSF is visible. That patient underwent separation surgery. And so here is a post-op myogram where you can see that you have reconstitution of the CSF space around the spinal cord. You can see we took out very little of the vertebral body in itself. Most of it is this lytic lesion. This is mostly from the lytic lesion itself that's been kind of cored out of the vertebral body. We've really done more of a wide laminectomy and gone down the pedicle that was involved and really sucked out the tumor there that was compressing on the spinal cord. And you can see with a very minimal surgery, you have a complete reconstitution of the fecal sac. And this was enough for our radiation oncology colleagues to provide a good treatment plan. Now, looking at tumor control when you're doing this combination of separation surgery plus radiosurgery, what you'll see is that with this very high dose of ablative radiosurgery, you're having local progression of about 9%, and that corresponds with what we mentioned before. When you give a high dose, you can get to about low 90% control rate. And we've seen in this one study, there was also some better results with even a hypofractionated high dose, reaching about 4%. These are patients that receive 10 Gray times 3 fractions. And then if you do give that low dose, you're still not going to get the same benefit. So when you're giving 6 Grays over 5 fractions, times 5 fractions, you'll have a 22% progression rate of failure rate. Based on these studies, The AOSpine group recommends that clinicians should surgically debulk asymptomatic high-grade epidural tumors before proceeding with radiotherapy to optimize local control, and that separation surgery in conjunction with post-op radiosurgery provides safe and effective tumor control, especially when it's a high-grade core compression from a radiation tumor. Finally, we'll go briefly into, again, the mechanical component. And this is a big focus now that as the possible role for surgery for debulking tumor is sort of becoming more narrower, I think one of the big things we need to look at is the mechanical aspect, especially since this is where we come in, where oftentimes this may not be on the forefront of the minds of our oncology colleagues or radiation oncology colleagues. And really, it's important to realize that tumor-related instability is very different than what we see in the trauma populations. For example, at Harborview, when you get a lot of burst fractures. And this is because there's differences in bone quality and healing potential for cancer patients. And really that most of our cancer patients have completely intact ligaments, including the PLL and all the posterior elements typically. So when we talk about patients that do have tumor-related mechanical instability, that pretty much requires stabilization if the patient can handle it. Because tumor radiation is not going to address any of the instability issues. And it's important to distinguish between what is considered cancer pain or biologic pain versus movement-related pain. And oftentimes we end up giving steroids to a patient and see if they improve. If they have improved, it's probably that they have biologic pain rather than mechanical pain. And the type of complaints a patient may have is very level dependent. If they're having a tumor in the cervical vertebral junction, they're going to be complaining of head positioning, pain when they rotate their head. If it's subaxial cervical spine, they're going to be complaining about flexion extension. In the thoracic region, just extending or laying aside becomes very difficult for them. And then finally, in the lumbar spine, they'll get more symptoms of radiculopathy. And again, just going back to the SIN score, super helpful whenever you're evaluating a patient with spine metastasis. And just to give you an example of the various options, if someone has a relatively lower SIN score, you may be able to do a more conservative, minimally invasive procedure. So here's a patient with a SIN score of 9 with a solitary met in the lumbar region. So this patient, has a mild back pain, nothing too severe. This patient may be a good candidate for a vertebroplasty or kyphoplasty. Versus someone with a higher SIN score in the 14, which is for that high range, low part of the high range. You get a tumor here that's in the junctional area that has more biomechanical pain. If this patient does not need a decompression because there's not a high-grade compression, then this patient may be better served with just doing a simple percutaneous fixation. Here's some examples from my fellowship. And then finally, if someone has a very high SIN score, for example, a tumor at the craniovertebral junction, they will definitely give us a traditional open infusion procedure. Moving on to the systemic, I think this is the most interesting part for me as for my research endeavors is really that we don't have a great understanding yet of how to evaluate a patient with multiple comorbidities and their tumor burden. And we're getting closely, every year we're getting more and more papers out about how to really understand that systemic part. Here's just an example of a paper from the Hopkins group, and they created a metastatic spine tumor frailty index. Frailty has been a big buzzword in recent years in various surgical fields, trying to find how frail or how sick a patient is. And this one study showed that by looking at these various factors, they can sort of predict how sick the patient's going to be in terms of their perioperative outcomes. But it's important to realize that this is a moving target. We may say someone with this type of cancer A has 3 months to live, and then the next month a new paper comes out with a new biologic or targeted therapy, and their treatment paradigm completely changes. Here's just an example of a landmark study in 2015 for melanoma, when we're starting getting monoclonal antibodies, and their treatment paradigm and survival has completely changed. This has completely revolutionized this one specific cancer type. And so it's very important for us as neurosurgeon oncologists is to really keep up with the literature for all these various subspecialties to really have a better understanding of what's the predicted mortality of this patient. So for us, I think the biggest thing when you see a patient coming in through the ER is really trying to understand the cancer staging. I often get, even if the patient has already a lumbar MRI because they have lower back pain, get an MRI that's totally fine. You often will see other lesions. Talk to the oncologist about when their most recent PET scan is, and then various labs. If the patient has liver mets, they may have other issues in terms of blood factors, like platelets and FFP, things like that. They can make a big issue in terms of hemostasis and OR. And then really the main goal for us is trying to optimize the OR. So coordinating with oncologists for patients with lung cancer or lung mets, getting pulmonary function tests in terms of cardiac function. And then also there's a very high rate of DVT. Another study from NSK showed that patients with spine mets who are ambulatory have a 6% rate of radiographic DVT. And if that patient is non-ambulatory, by the time they're seen in the ER, that jumps to a 24% rate of DVT. So we pretty much got an ultrasound, a Doppler study of every patient that came in through the ER with spine mets and would proceed with a IVC filter before doing surgery if the patient's neurologic status can handle it. Now, for the last part of the talk, I'll just be going a little bit more of what I'm interested in this field, which is really surgical advancements and how we can incorporate minimally invasive techniques into our armamentarium for surgery. This is really based off of using image-guided navigation to help us with smaller incisions. So just a few quick examples before we end the talk. The main things that I'm interested in are incorporating percutaneous fixation, using shorter constructs with cement augmented pedicle screws, doing a decompression via tubular retractor, similar to the way we do a microdiscectomy rather than a traditional open surgery. And then I think the ultimate goal will be, can we incorporate endoscopy regularly and sort of getting to that epidural compression with an endoscope and really just debulking the tumor there. And again, all these, there's a lot of things we can do. The question is, should we do this? And the real goal in mind is, can we have a shorter, safer surgery and hospitalization? Then that way we're minimizing delays to radiation and systemic treatment. So just as a couple of representative examples of percutaneous fixation and how new technology with image-guided navigation makes such a big difference. So just as an example here, you can see that for my percutaneous screw cases, I start using navigation before I even open skin. I'm making my incisions, planning them based off of the imaging from the very beginning to see if right here, skin incision is going to give me the best target to the pedicle screw. Then you can see as we go back down, again, using it for every step, cannulating the pedicle, placing the screws. And then I think a big advancement in the last 3-4 years is the FDA approval of fenestrated pedicle screws. And this has been around in Europe for more than a decade. But really, what surprised me during fellowship was that we could get away with short constructs, going from the traditional 2 or 3 levels above and below the tumor site to really just using fenestrated screws, depending on the cement. And the idea here is that these patients, given that their expected survival is only a few years, the chance of a hardware failure is fairly low, and then that cement really helps us fight the poor bone integrity. So whereas previously we would be doing very long constructs because of that poor bone quality, now we're opting for a shorter construct, and depending on that cement, kind of really keep the screws in. And here's just a quick representative example of in the OR under fluoro, we already have our screws placed, the kypho plastic needle as well. And then you can see with the cement, you can get really good bony purchase of these screws. And then in terms of decompression via tubular retractors, here's just an example again of a patient with who presented with lumbar radiculopathy from this epidural spinal cord compression. And again, the question is, how much can we do? on a patient who's very sick, and how can we get away with smaller surgeries. You can see here they have a little bit of cord compression, and they were hitting a nerve root. And for this patient, we went down with a tubular retractor. We did just a simple radial stereotactic. You can see how little bone we removed, but it was enough to visualize the exiting nerve root, decompress it. We supplemented it with a posterior fixation, one screw above and below. And this patient was home post-op day 1. Based off of this initial experience with using MIS techniques, the MSK group has started developing an MIS algorithm of how we can incorporate these techniques into future management. So basically, here's a quick paradigm that they've been postulating, where if a patient presents with a spine met, but it's just causing compression fracture, the first question is, do they need a decompression? If the answer is yes, you can try to do a perk screw with a mini open, either using a tubular retractor, as in the previous example. If they don't need a decompression, but they have mechanical radiculopathy, can you do that unilateral technique, which is what I just showed you. And then if they don't have radiculopathy, then they don't need decompression, and then the core compression is relatively low grade, perhaps you can get away with just percutaneous screws. And this is mostly if the tumor is in the vertebral body. However, if there are posterior elements that are involved, we would typically present, we do both a percutaneous screws and kyphoplasty. And then finally, if you don't have posterior elements involvement, and it's just that anterior column with a vertebral body fracture, we would defer this patient to our IR colleagues who would do a kyphoplasty. Okay. So again, the AOSpine group recommends that you can perform MIS, and this will provide safe and effective stabilization and decompression in patients with spine metastases. It's super helpful if you have a patient that's fairly sick and you just want to do as minimal of a surgery as possible to get them back home with their family. So in conclusion, the NOMS provides an evidence-based decision framework for integrating radiation and surgical treatment options for metastatic spine tumors. And now with the advancements in systemic therapies and radiation therapies, our role for surgery has really shifted, and we have to be very clear with our indications, where the main things that I see as for our main roles would be separation surgery to create a safe radiation target, any sort of decompression or separation surgery to preserve neurologic function. And finally, the main one was going to be for stabilization for when a patient has mechanical instability. And I think the final concluding point would be that we can definitely incorporate these minimally invasive techniques, especially with the aid of image-based navigation, to really achieve these surgical goals while minimizing disruptions to systemic therapies. Thank you, guys.